as well as novel methods of drug delivery, bypassing the blood-brain barrier. You're truly a inspiring figure, an excellent chairman, a great teacher, and someone that I genuinely very much enjoyed working with through my last 7 years of training. But I won't take up any more of his time. Thank you for joining us this morning, Dr. Woodworth. We appreciate it.
Great. Thank you very much, Dr. Pratt. It's a pleasure to be with you all today, and really appreciate the kind introduction and the opportunity to speak through this great portal into our field, the Seattle Science Foundation. And I would just like to give a strong sort of shout out to this organization and what they're doing to help advance knowledge, innovate, and really in the end improve patient care for patients with neurosurgical and other challenging medical disorders. So I'm going to speak with you today about focused ultrasound and really what I think it means for the future of neurosurgery, which may even be a new field within neurosurgery that we might one day consider neurosonics. And I'll propose some ideas for that today. But more than anything, what I'd like to do is get you thinking about as surgeons, as medical professionals, how we can move the needle, how we can really leverage our access and our perspective really on the conditions that we treat and the patients that we care for to improve things and not just necessarily maintain the status quo. And it's my firm obligation to our department here and to our patients that, for those patients that have conditions that we know don't have great outcomes, that we don't just settle for the standard of care. And you'll see some of the ideas around that today. So what I'd like to do is first start by sharing any disclosures. I don't have any financial disclosures or any financial relationship with any of the companies or ideas that I'm going to be describing today, including patents, pending or otherwise. And we have numerous grants that are funded to support some of this work from the NIH, the Focused Ultrasound Foundation. And some of the clinical trials that I'll speak about today are funded by a company that where you'll see the device called the Exablate system today from Insightec. And then the Keep Punching Foundation does fund our laser interstitial thermal therapy trials, which will not be the focus of this today. So before I get started, I'd like to just recognize a very large team that has been part of this from the beginning. Some of those folks are listed on the left here from the University of Maryland, and then on the right, the team from Insightec and others. And it really has been a huge collaborative team that have put a lot of this work together and created the strategy to move some of these technologies into the clinic that you'll see. So when we think about early phase of neurosurgery, we think about this gentleman here, who many of you know, Harvey Cushing, sort of the founder of neurosurgery in North America, at least. And, he advanced many new surgical techniques, as we all know, including the transfemoidal approach there. You can see with his very advanced headlight that he was using at the time and a surgical mask, which were all new ideas at the time. And he made great progress for the field and really established the field as we know it today. And then, sort of at the beginning of my time as a faculty member in the 2010, 2011 period, we started to use things like tractography more frequently and using this for transcortical, transsulcal approaches to deep structures, inserting electrodes within the brain to modulate neural circuits that are dysfunctioning and other conditions that could be responsive to that. And then also transfenoidal and minimally invasive approaches to the skull base and other areas within in and around the brain. All of this is exciting and still continues today. But what also came around at that time was a recognition that new technologies could be merged together in exciting ways that could potentially be transformative. And this actually was recognized in Time magazine in 2011, when the editors and contributors to this issue realized that there was a coming era of high resolution imaging with the ability to use ultrasound energy as opposed to other energy forms like radiation, but ultrasound energy to modulate tissues in and around the body, not just the brain. So many of us know ultrasound in clinical practice. It's used for diagnostics, of course, in some cases for therapeutic purposes with rehab. But what we're going to talk about today is a whole new way of envisioning ultrasound. And what it really is the ability to focus ultrasound beams in and around the body, specifically the brain, with new technologies like this. This is the Insightec Exablate system, which is a hemispheric array of over 1,000 small ultrasound transducers that each can be directed into a focal region of the brain or the body through piezoelectrically controlled computer models that take into account the human skull in the process of focusing each individual beam. And this is what it can look like. The data that comes into the system is the high resolution CT scan of the skull of that patient. And that data is entered into the system. And here you can see a representation of the transducer activation map and how the system can turn on and off some or all of these transducers, and also angle each one specifically to accommodate for that patient's skull density, thickness, and angulation itself. So essentially what this is doing is turning the skull from a diffractive absorptive source into a filter, or in some ways even a lens that can then focus energy the way we would with light to start a fire in this example. So this is an exciting idea, but it's not new. Like most things, when you look back in time, you'll see that others have thought of them before. And this is another example of that. In the 1950s, neurosurgeons in both Europe and the United States, and Illinois specifically, and also here at the University of Maryland, William Mossberg, were working on this. They understood the power of ultrasound energy as a therapeutic, not only diagnostic, but therapeutic entity. And I'll explain a little bit more about that in a moment. But this group made significant advancements in the 50s and 60s, focusing ultrasound. Here you can see a 4 transducer system that they were using to focus energy into the brain of animals and even some humans to create small lesions for functional neurosurgery. And they realized then that they were able to create effects in the brain with relatively little disturbance elsewhere, which was very powerful at the time. And you might ask, well, why did it stop? Well, what they ran into was a limitation of getting the energy through the skull and heating at the surface. And they couldn't get it to work without causing significant superficial pain. So they abandoned this, and this group went on to develop the gamma knife. They changed their radiation source to radiation energy, and that was the beginning of stereotactic radiosurgery and stereotactic procedures, similar stereotactic procedures. So here's the gamma knife, as many of you know, and this uses a very similar concept of taking single beams of energy and focusing them to a single target within a given structure, the brain as an example. And we all know how this can be used to treat tumors, trigeminal neuralgia, and other conditions in neurosurgery. So why ultrasound? I mentioned that it is a unique energy source earlier, but what's really special about this energy form is that it can be tuned and used in diverse modes, and it can be used to heat things up. It can be used to mechanically perturb things. We also know how lithotripsy is used to break up things like kidney stones. So all of these are different forms of ultrasound energy that can be uniquely tuned to serve specific purposes in and around the body or to modulate disease. So a group from our team put this into a review. David Hirsch was a resident when Nathan Pratt was here at the University of Maryland and wrote this great paper envisioning some of the potential uses of ultrasound with these different modes, both thermal ablation, radiation sensitization, so-called sonodynamic therapy, where agents are activated selectively by ultrasound energy in the body, blood-brain barrier disruption, we'll talk about more in a moment, immunomodulation, ultrasound-assisted drug delivery, and more. All of these can be envisioned based on how the ultrasound is tuned and used to modulate specifically tissues and diseased areas within the body. So at the University of Maryland, we're advancing this technology in multiple different areas of neurosurgery and neurological disease. Essential tremor is one, and that was the original purpose or indication really for the FDA approval of the first device. Parkinson's disease has come along next. Dr. Gandhi here has been focusing on chronic pain and trigeminal neuralgia. We have multiple clinical trials ongoing for this. And then the blood-brain barrier disruption work in and around brain tumors and other conditions has been work that I've been focused on. But again, you can see here a team across neurosurgery, radiology, and neurology that has really been championing this here at the University of Maryland. And here we are with our number of cases to date as of February 22nd. We've treated almost 230 patients for various conditions here with focused ultrasound. So as I mentioned, it really is a synergy between these other specialties and disciplines that cross into neuroscience And it's this collaboration that really makes all of this happen. Without this, it would really be hard to do. It's hard to get time on an MRI scanner to do procedural work, and we all know that. So things like that have to be smoothed over. And the way that happens is if there's a win-win partnership to advance the care and innovate these devices. So when we think about the different indications of use for focused ultrasound, one is, as I mentioned, thermal treatment. So thermally ablating different regions, such as regions of the thalamus for essential tremor treatment, but also the ability to potentially use mechanical dosing to mechanically perturb either blood vessels or regions within the brain for other indications, such as drug delivery or immunomodulation. But the key to all of this is the ability to create a real-time monitoring strategy so that you can gauge what's happening moment to moment while the treatment is going. So not only do you have advanced imaging with MRI, but ways to actually monitor the energy delivery real time. And so on the left, you can see an example of that with MR thermometry in the ability to create a thermal imaging field within the target region for that real-time temperature information. So you know how much energy is being delivered, how much the temperature is changing, and if the target is accurate, because you can see where that spot is overlaid on the high-resolution MRI. In a similar way, we are developing ways to measure mechanical energy real-time through what's called acoustic emissions feedback monitoring. So it turns out that when ultrasound energy is sent into a structure, certain things resonate and send energy out, in the same way that you can think about fluorescence microscopy, where you might send in certain excitation, pulse of energy, and then you get an emission from the fluorophore in the field. In this way, we can actually measure the acoustic emissions in certain patterns, and the way those patterns come back to the machine or come back to the detector can reveal exactly how the energy is being delivered and the effect that's happening at the target. So this creates these closed feedback loops that are very powerful in developing the technology. Here's an example of a closed feedback loop for the treatment of essential tremor, where a target in the thalamus is seen on the MRI. The treatment is delivered, and you can see the focal spot in the target region and the degree of energy deposition and temperature rise. And real time, you can go in and monitor the patient. These patients are generally not under anesthesia for these treatments. They're very comfortable lying flat in the MRI scanner. And you can actually test them to see if they're having any side effects or having the desired effect. Here you can see the spiral tracing of a patient undergoing an essential tremor treatment, where it starts very fuzzy and very inaccurate, and then it becomes more and more accurate during the treatment. And this is one of those things in neurosurgery that some of us may have seen, where the patients come out of the procedure and are literally changed. And often they'll cry and not know what's just happened to them. They can't even believe it. The closest thing I've seen to this has been a patient treated with trigeminal neuralgia that was suicidal. And they went under surgery. They had general anesthesia for microvascular decompression. And when they woke up, they no longer had that searing facial pain and literally just wept. And it's just such a life-altering moment for that patient that was literally going to take their own life because of the severity of their condition. While this is not quite that severe, where patients are considering suicide because they're so tremulous in their daily activities, it's pretty similar. And these patients can now interact with their grandchildren. Often they're older. They can go out to dinner for the first time without spilling all over themselves. It's really transformative to see this happen, and all of it happens with the patient lying there flat in the MRI scanner. It's truly remarkable to see. Here's an example of the first patient treated for Parkinson's disease, not essential tremor. And she was an athlete who developed early onset Parkinson's disease. And you can see she had a very magnetic gait and limited movement. And she was eager to contribute to this new technology and field, and screened into the clinical trial, the first patient treated in the clinical trial for Parkinson's disease. And following this treatment, about 1 month later, this is how she looked. Much more fluid movement, and extremely happy with her ability to now get around. And she was actually a very significant athlete as well, and she continued to do those things after the treatment. Here's an example of what the lesion can look like at MRI from day one. We see some surrounding T2 hyperintensity and a focal region there as well. On day 7, you can start to see the lesion developing. Over time, by 30 days or so, the edema has resolved, and by 3 months or so, you can see the small lesion in the target site. So very, very targeted and controlled, and the side effects can be minimized through both real-time targeting and adjustment of the target, but also management of any edema over this period. So this was, of course, very much in the media at the time, and just recently, this trial has completed for Parkinson's disease, and now we're going to be seeing this approved by the FDA in the very soon. So we'll have yet another indication for use for this focused ultrasound device. The beginning of this all came from a group at UVA, at Toronto, University of Maryland, and others that put together the focused ultrasound clinical trial for essential tremor. This work was published in the New England Journal and really kicked off this new field of neurosonics. So again, getting back to the differential modes, that really covers the early use and indication for the thermal modes of energy. But I'd like to begin shifting gears a little bit and talk about these mechanical modes of energy and how these can be equally transformative and potentially impactful in neurosciences. So the idea that came around, maybe 5-10 years ago was the idea that these ultrasound contrast agents that we use for diagnostic echocardiograms and other uses could potentially be leveraged to create unique effects in and around blood vessels by activating them in an acoustic field with focused ultrasound. And this is the idea that really launched the concept of focused ultrasound mediated blood-brain barrier disruption. And these clinically approved ultrasound contrast agents were really the beginning of this exploration. And when we think about indications for this, not unlike how we thought about indications for essential tremor treatment, we look at diseases like glioblastoma, where in surgery we can commonly remove the entire contrast enhancing mass, as you can see on the left, and have very minimal residual contrast enhancement following the surgery. But we all know that even after chemo radiation treatment aggressively for 6 weeks and then 6 months following, by 12 months, we start to see some new contrast enhancement around the original resection cavity, and that can rapidly progress within the next few months to be contralateral. And these patients don't live on average more than 15 or 16 months median survival. So we need new ways to improve the adjuvant therapy for this disease. I'm not at all suggesting that surgery is not indicated for a large mass effect creating lesion like this. But I think the residual invasive disease that's woven into the fabric of the brain adjacent to these large tumors needs better treatment. And we know that at least in some form, the blood-brain barrier, might call it the blood-tumor barrier because we know there are tumor cells there, but the blood-brain or blood-tumor barrier in this region is not compromised significantly. We don't see significant contrast enhancement in these regions, quite the opposite. We see this T2 infiltrative pattern with minimal contrast enhancement. And it's this region that became the focus of our ultrasound-related efforts. Could we selectively open the blood-brain barrier in these regions and get therapies in? Because we know that the majority, 90% or more of patients that recur with glioblastoma and other high-grade tumors similar to this, recur in the 2 to 3 centimeter margin surrounding the original tumour. Granted, there are some patients that have aggressive disease that grows quickly and becomes bilateral, but in most cases, if we can target energy and delivery of drugs into this region, we're likely to have a big impact on the disease progression natural history. So this is the paper that really kicked this all off in 2004 by Claire Bohannon and Nathan McDonald, who are still actively involved in really leading this field of focused ultrasound mediated blood-brain barrier disruption. And I give them huge credit for uncovering this mechanism of microbubble dynamics in the ultrasound field and how this could be used to temporarily perturb the blood vessel wall and the blood vessel unit, the neurovascular unit that is really the blood-brain barrier. And in this way, temporarily open the blood-brain barrier for purposes like drug delivery. So when we began working on this back in 2009, we were challenged to try to figure out a way to decouple all of these things that were going on at the same time and ideas. Could we make it accurate? Again, we saw we could do it with the thermal energy, but it wasn't clear we could do it with mechanical energy in the same way. So could we make it accurate? Could we monitor the effects real time? I mentioned that earlier, but that wasn't possible yet. And then were we ready to couple this with a drug? And if so, which drug? And how would we prove efficacy without being able to do these other things, like confirm accuracy and monitor safely the treatments in real time? So we were trying to figure out a way that we could decouple these things to move the field forward. And this was the idea that came out of it. And again, this brings into mind how, from a surgical perspective, we have the ability and the conceptual perspective to be able to envision things like this. And this is what it can look like in the operating room when you're taking out a T2 hyperintense tumor that you can see on the MRI scan in the upper left corner. It doesn't look that different than normal brain. You see some abnormal tissue there, but there's also areas that are just swollen. They look relatively normal. And you say, well, it'd be really nice if this was differentiated from the normal brain. And certainly we use mapping also to guide us and understand whether there's functional tissue within this. But it would be much better if we could turn this into this. We all know the use of fluorescein and other fluorescent adjuncts in surgery and how powerful that can be in guiding surgical resections, whether those are 5-ALA based or ICG based or fluorescein based. But here is an example of fluorescein injected into a contrast enhancing tumor and how visually distinctive that can become in the operating room. So we envisioned, well, if we can turn a T2 hyperintense non-enhancing tumor into a fluorescent tumor by giving it more intrinsic contrast enhancement within the surgical resection volume that's planned, that we could advance this field in a new way by showing that we can use blood-brain barrier disruption as a surgical adjunct. So this is the procedure that we envisioned, where the patient would come in the morning, and you can see the red boxes there. The speckled red boxes are just our standard operating procedure. So we're not significantly changing the workflow in the morning. And at the University of Maryland, we do get our scans in the morning before surgery, not the day before. So the patient would come in to the imaging center in the morning early and have their standard imaging study. But in this case, they would have their frame placed, a frame placed for securing their head and registering them into the system and being able to put them in this hemispheric array for the focused ultrasound. So that's different, obviously, but otherwise the imaging is similar. We get the imaging, we apply focused ultrasound to the region of the planned surgical resection volume. We get a confirmatory MRI to follow, and then the patient can roll off to the operating room for surgery. And so here's what that first patient looked like. It was the first patient treated in the United States with blood-brain barrier disruption, focused ultrasound-mediated blood-brain barrier disruption. And here you can see her tumor in the frontal lobe had minimal intrinsic contrast enhancement and a T2 hyperintense infiltrative pattern. And here's what it looked like after focused ultrasound. At this time, we were only using a 3x3 grid of ultrasound spots. As you can see, some evidence of that grid in the target region there on the bottom left. The middle bottom image is the gradient echo image that does not show any significant spots or evidence of damage, which was important at the time. We didn't know if we were going to be causing any microhemorrhages or any other changes in the brain, so we were monitoring for that. And so this was the first demonstration of new blood-brain barrier disruption within a T2 hyperintense infiltrative brain tumor in a human being in the United States. And this sort of set off a huge technology development process because we realized that not only it's possible, and we were able to visualize it and monitor it in real time. When we took this patient to the operating room, we registered their MRI scan immediately to the brain lab system. We were able to navigate directly to this new contrast enhancing region. We had injected fluorescein dye into this patient. And again, we only saw fluorescence in that spot where we had targeted that energy. And so it's, again, demonstration that we were able to basically transform this area of the tumor into a fluorescent and now contrast enhancing area. So when we took this area out, this patient did have some intrinsic contrast enhancement lower down in the tumor. So we had that as control tissue. And we could see bright fluorescence, as you might imagine there, and also a more aggressive looking histological pattern on the H&E. In the other non-enhancing control region of this tumor, we saw minimal fluorescence intrinsically and a very similar H&E pattern to the focused ultrasound. Note, no evidence of significant tissue disruption in the focused ultrasound treated histology on the bottom. And that is the area exactly where the contrast enhancement was based on the neuronavigation. And again, comparing the fluorescence, we can see significantly increased fluorescence in that area confirming that we actually did open the blood-brain barrier and the fluorescent dye did get into those tissues. As a control, we also looked at the blood vessel density within these regions, and we did not see significant difference comparatively. So that did not change these results. So this is how the system can work in the context of blood-brain barrier disruption. We have these focal spots, and generally for essential tremor treatment, you only need one of these spots. But in the context of blood-brain barrier disruption, we want to be able to treat a large volume over a short period of time. So how can that be accomplished? In the first patient that we just looked at, we used one of these 3x3 grids, which is how the system was initially set up to test whether it was possible for the system to actually beam steer through the grid, sort of like a 3D printer. So it picks a spot, hits that spot, but all of the transducer arrays, again, have to move in harmony to be able to do this, which is a true technological challenge. But that challenge has been solved. And so the system can steer through these grids, in this case, a 3x3 grid, and focus the energy, listen to the emissions coming out, and give an equal amount of energy and dose, essentially, to each spot, such that we can tune it for blood-brain barrier disruption in a larger volume. So this is what it looks like when we look at the emissions pattern that comes out. On the left here, you see a model emissions pattern from an animal treatment that we did in a rodent that received the exact same settings that we use in humans, the microbubble dose, et cetera. And you can see these very clean acoustic emission spectra that come out. You have a subharmonic, the fundamental frequency from the transducer, the elements, and then the ultraharmonic and harmonic. And so the question becomes, which of these is most representative of the bioeffect that's desirable? And what we're able to determine, and others determine, is really at this time the subharmonic intensity pattern and that emissions frequency is that pattern that is most consistent with stable oscillation of the microbubbles in the blood vessels. And what we don't want to do is create unstable oscillation, which is called inertial, can be called inertial cavitation. That can cause dangerous, harmful effects, could be used in the future to mechanically damage tissues. But right now, we were trying to do much more subtle treatments of the blood vessels, and we knew we wanted stable microbubble oscillations to accomplish this. And that correlated most with this subharmonic pattern, which is what the system is now tuned to. So this gets us back to this idea of, can we create this real-time monitoring strategy using acoustic emissions monitoring? And in the system, what we now have are 8 hydrophones in these, what you see in these orange circles here. These are 8 separate hydrophones that can be turned on to listen to the energy coming out in real time while the energy is being delivered in. And it's this constant energy in and listening out that allows the system to, every millisecond, tune itself to a desired effect, in this case, a mechanical effect for blood-brain barrier disruption. So this is what it can look like in real time, similar to the closed feedback loop that we have for essential tremor and thermoablative treatments. We have now a closed feedback loop system for these mechanical treatments. And so what you can see is on the preoperative MRI or pre-procedural MRI, we have a surgical resection cavity here. We can draw now these subspot grids around the resection cavity and ask the system to deliver the energy to each of these subspots in a relatively uniform way and create the desired effect for stable microbubble oscillation and thereby blood-brain barrier disruption. So as the system works, it can actually record the energy in real time. And what we see in the middle image here is a heat map of the mechanical dose delivered into those regions. It's not technically, it's a heat map in just how it looks, but there's no thermal change happening here. The red is higher mechanical dose deposition, and the blue is lower mechanical dose deposition. And we measure this by what we call subharmonic or harmonic dose, abbreviated here, HD. And so in a low harmonic dose setting, you see very little subharmonic intensity peaks through this spectra. At a medium harmonic dose setting, we see a medium or moderate amount of these subharmonic peaks. And then at a higher harmonic dose, we see many more of these subharmonic peaks. Again, keeping them all below this line, which is the line over which we start to see this inertial cavitation. And again, the patients are awake and we can test them real time. So here's an example of what one of these treatments can look like while it's actually being performed. We have drawn a subspot grid around a resection cavity. We see the T2 weighted image here on the screen. The acoustic emission system and closed feedback loop system is driving over here. You have the power going in, the green line, and the energy coming out, the orange lines. And the system is rapidly cycling every millisecond to adjust the power to create the desired peak. And over time, what we see is the acoustic energy map develops in the field, and the system is actually delivering energy to a given dose that's prescribed by the provider prior to that treatment. So this is what this can look like in the post-treatment scan. And so in the early days, we saw a relatively non-uniform deposition of energy, in part because of differences in blood vessel density within these regions, and also just differences in the tissue characteristics. So the system was not able at the beginning to achieve a relatively uniform mechanical dose throughout the target region. And so we were able at that time to look at differences in harmonic dose within the target regions and gauge the degree of contrast enhancement. For example, here, a low amount of harmonic dose corresponded with a relatively little amount of new contrast enhancement following the treatment. A moderate harmonic dose corresponded to a moderate amount of new contrast enhancement, and a relatively high harmonic dose corresponded with a higher amount of new contrast enhancement, beginning to create this ability to envision a sort of dose response to a desired bioeffect, in this case, new blood-brain barrier disruption. So with this idea, and the idea of conformally shaping the acoustic energy delivery around a tumor resection cavity or a disease region of the brain, others are using this, as you may know, for Alzheimer's disease and other conditions. We are envisioning the ability to, again, deliver the energy, open the blood-brain barrier selectively in these regions around the resection cavity, and then think about ways of delivering drugs into these regions. So as the next phase of this development process, once we saw this possible, the question became, can we do this monthly? Can we deliver and do these kinds of treatments when a patient would be receiving chemotherapy? So as many of you know, after surgery, patients go on to receive 6 weeks of combined chemoradiation treatment when they have a high-grade glioma, designated here as the black bar on this timeline. And then following that, they currently receive cycles of adjuvant temozolomide, which is an oral chemotherapeutic alkylating agent. It's given monthly, generally for 5 days with 23 days off in cycles over 6 months, sometimes longer. So we thought, well, this is an opportunity to see if we can overlay ultrasound when those patients are receiving their chemotherapy, deliver these treatments monthly, and see if it's feasible for patients to undergo this at this time in their disease management. So this was our next clinical trial listed here that is now coming to a close. Actually, we have one more patient left to treat on this trial nationwide. And so the idea again is, can we use monthly treatments of focused ultrasound energy to eventually partner those with new drugs and maybe new drug cocktails to treat these patients, and do it through better understanding of that patient's disease and understanding from both a molecular perspective, but also a regional distribution perspective on MRI. So here's what this can look like in a rodent as we envision new chemotherapeutic concepts. On the left, you can see a patient not treated with focused ultrasound, but receiving our chemotherapy-loaded nanoparticles. And on the right, you can see the new blood-brain barrier disruption in the frontal lobe of this animal. And when we deliver the chemotherapy-loaded nanoparticles that are fluorescent, we can see a huge deposition of those nanoparticles into this target region and not elsewhere. Very exciting early evidence that this could work for not only current drugs that are available, but new drugs like nanotherapeutics, antibody-based therapeutics, and possibly cellular therapeutics. So this is all an exciting concept, but we also had an idea as these trials started progressing of, well, what if not only can we get things into the brain through focused ultrasound, but we're also releasing things out, things that would help us potentially manage the patients better, such as tumor-specific biomarkers that are not otherwise released into the circulation, such as circulating tumor DNA or exosomes or protein biomarkers. So I began talking to my co-resident who is currently still at Hopkins, Dr. Chetan Bedagauda. And he had written this really exciting paper in 2014. It's one of the most highly cited papers in Science Translational Medicine on the detection of circulating tumor DNA in solid tumors, both early and late stage. And one of the figures from this paper showed very clearly that gliomas of all types did not release significant amount of circulating tumor DNA into the bloodstream, such that we could not do liquid biopsy or liquid biomarker assessments of these patients as we could with these other solid tumors in this emerging and exciting field of precision medicine and personalized medicine. So we thought, well, what if we can treat with ultrasound an area of a brain tumor and potentially open the blood-brain barrier in that area, sample the patient's blood before and after the focused ultrasound so they serve as their own control, and then see if we can detect any new changes in the blood. Any new changes would likely be derived from the ultrasound treatment because they weren't there right before. And now you can sample the blood 30 minutes, 60 minutes, 24 hours after ultrasound and have multiple different time points to look for that needle in the haystack. So this was the subject of a grant from the NIH that Dr. Bedagauda and myself secured a few years ago, and has been a hot topic that's developed since then. So what we found in the first 3 patients was there's a significant change in the amount of cell-free DNA in the bloodstream after ultrasound. So this did not get us to the question of, is this tumor specific yet? But certainly there's a large amount of DNA released that's new, and it's scored compared to the original sample right before ultrasound. So something is going on, something's being released. The question is there tumor specific material in there that we can actually use to guide treatments and inform the care of patients? And that's where we are today. They don't have the answer for you yet, but hopefully will. Our colleagues at the University of Toronto had similar ideas and published their work last year in neuro-oncology. Here's a figure from their paper, Ying Meng and Nir Lipsman, who have been working very closely with us on these focused ultrasound blood-brain barrier projects and still do today. But they saw very similar findings, pre and post-focused ultrasound, significant increase in circulating cell-free DNA in the bloodstream. So this is a huge opportunity to potentially use ultrasound, not only in the brain, but in other parts of the body to potentially release tumor-specific biomarkers to aid in diagnostics and treatment planning. So again, there's a lot of possibilities here, and I've just reviewed a few in the context of our clinical trials. But I encourage you to look into this area and consider how this really could be a changing part of neurosurgery and our role as surgeons and medical practitioners in advancing technologies like this for new treatments for patients with glioblastoma and other neurodegenerative conditions. So it's a very exciting time, and we're very encouraged with these early findings that this technology will be the foundation, I think, of a new field of neurosonics in neurosurgery. So in summary, focused ultrasound is a highly tunable energy modality with both therapeutic and diagnostic applications. These new transcranial image-guided systems are rapidly advancing, and they're offering new non-invasive strategies for a broad range of neurological conditions. And specifically, this mechanobiological control of the blood-brain barrier with spatial and temporal resolution now may transform how we think about central nervous system drug delivery. Again, I'd like to thank this large team from the University of Maryland and Insightech that have really helped put all this together, and I'd be happy to take any questions. Thank you very much.
Graeme, it's Cam McDougall. Are you able to hear me, Graeme?
I can. How are you?
I'm good. That was a spectacular talk. Just thanks so much for giving that. It's just amazing and wonderful work you're doing. How long does the blood-brain barrier disruption last, do you think?
So in animal models, and even up through monkeys, we've seen the blood-brain barrier stays open in the normal brain for about 4 to 6 hours, as measured by contrast enhancement with MRI scans. Now, it may be open more subtly, longer than that, and it may be open for a different period of time in regions where there's infiltrated tumor. So we're studying that in these patients now, as best we can. We can't get MRI scans every hour, of course, but it does look like it's mostly closed within 24 hours. So I don't think it's a prolonged period of time.
And how are you selecting the fields? I mean, we know that some tumors, are much more dispersed initially than we can appreciate on the MR scan. I'm just wondering how you judge how big a field to open the blood-brain barrier in, and what the limitations are on the field size for doing that.
So the only limitation we have currently is related to what we're approved to do at the FDA level. And over the course of the second trial that I was discussing with you, this one where we treat monthly in the context of ongoing temozolomide therapy, the total volume that we've been approved to treat has consistently gone up as we've shown safety and feasibility over the course of the study. It started a very small 1 cubic centimeter and now is up to over 60 cubic centimeters and soon to be 110 cubic centimeters. So we have a large volume that we can treat safely. And so the question is where to deliver the energy. Where do we lay those targets down? Where do we set up these sort of 3D printed energy deposition treatment zones? And so I think that's a very huge area of opportunity to study that. And so what we're looking at is designing prediction maps through AI-based strategies, whereby we could potentially down the road with an AI-based platform have an informed system to target regions specifically for that patient based on what the MRI scans are telling us, both pre and post surgery and in their follow-up. So I think there's a lot to be done in that space with regard to designing the target regions and also the dose. You might ask, well, how do you just told me that you can prescribe a dose to those target regions. How do you know what to prescribe? That's another big question. We don't know if a higher dose is necessarily beneficial. It might be the case that a lower dose over a longer period of time. The treatment that I showed you live was a 90-second treatment, and that's the treatment time that we've selected based on feasibility and it just seemed to make sense. But it might be better to do a lower dose over 180 seconds than a higher dose over 90 seconds. So these are some of the things that we're carefully looking at now to better design the treatments and make it work better.
I'm wondering though, the great work you're doing with Chaitin, showing the release of the DNA, couldn't you argue that the DNA release is just a marker of tissue injury?
Could be, absolutely, yeah.
So is that a good way to sort of monitor that question? About the timing and the dose and that sort of thing. Is that liquid biopsy of that?
Absolutely, yeah. That was our original goal when we started this. We wanted to look for a liquid biomarker of the effect, and to be able to see if we could correlate the effect in the blood with the dose of the energy, right, as a way to gauge safety. And that was the original purpose of the blood sampling that we set up in the clinical trial. And so when we started to see that there was an effect in the blood, we thought, oh, well, let's look a little deeper and see if we can get not only a measure of a biomarker of the ultrasound, but maybe also a biomarker of the tumor. So I don't know if it's going to be possible yet. Chaitin hasn't told me if it's possible. We're letting them run their assays and determine whether they can actually pull out tumor-specific DNA. But in the end, it may be just what you said. It may just be something that we use to monitor the effect, and maybe not in real time, but again, to use it to retroactively look back at a given treatment and say, okay, maybe that dose was a little high. Maybe we need to rethink this.
Very interesting. I want to make sure that everybody else has questions. Zach?
Yeah, good morning. Good morning, Graeme. Zach Litvak. I actually just want to make sure you saw there's a question in the chat from one of our stroke neurologists, George Lopez, about whether or not guided focused ultrasound could be used for lysis or liquefaction of hematoma prior to evacuation.
Yeah, that's a great question. And that's the subject of an R01 grant from a neurosurgeon at the University of Michigan, Aditya Pandey, who I know well. who has been working on that exact idea and has taken it all the way through pig testing and is beginning to the early stages of designing a clinical trial for that exact indication. So the short answer is yes, it's possible to use ultrasound to liquefy a clot and then drain it potentially much more easily, either through a catheter or other means.
Hey,
Any
Graeme,
other questions?
it's Rod. Really exciting to watch, you and Charlie Sanser kind of push University of Maryland into the next stratosphere. I remember when I was a resident at UVA, Neil Cassell had brought this technology over to the US. What's the reimbursement landscape nowadays? Has that gotten any better?
It's rapidly evolving, I would say, and it is also right now very state specific still, unfortunately. So it's not uniform across the US or even Europe, but it's become, with the data that's coming out and the papers that are being published and the outcomes that we now have, it's becoming much more of the conversation related to reimbursement. And so the essential tremor indication is reimbursed, and we're still working on details of facility related billing versus provider billing, these nuances that of course have huge impact on bottom lines. But the conversation is active. When we first started this process with billing, they just said, no, that's too experimental. We're not ready, but in the last, 3 to 5 years, we've gotten a lot more traction. And I think that the ice has been broken, I would say, with regard to getting reimbursement going. And so more to come, but I think we're on the right track to have good reimbursement for these treatments. Trying to make sure I didn't miss any other questions in the chat here. So there was a question about targeted genetic interventions that has been the subject of numerous preclinical studies, and some are envisioning clinical trials for genetically modified cells or genetically modified viruses being delivered that could potentially be gene editing in their eventual function. So certainly there's possibilities for that with focused ultrasound as well. Localized gene editing and delivery of gene editing constructs, whether those gene editing constructs are virus-based, nanotherapeutic-based, or otherwise, into focal areas of the brain and the body.
Well, if there's no more questions from the panelists, Graeme, I really want to thank you for your time this morning. That's just incredibly exciting work, and we're obviously going to be staying tuned to see how it develops. And thank you once again for taking the time this morning to share it with us.
Absolutely, my pleasure. Thank you for having me.
All right.
Yeah, great job, Graeme.
Thank you, Rod.